my absolute honor to get to introduce our DBLS speaker today, Dr. Lisa Dixon. For those of you who don't know Lisa, she's a professor of psychiatry at Columbia University, and she's also the director of the Division of Behavioral Health Services and Policy Research that's based at the New York State Psychiatric Institute. Lisa is actually also the director of the Center for Practice Innovations, which is basically a center that New York State's Office of Mental Health has to implement evidence-based practices and behavioral health programs throughout the state. She is an internationally recognized mental health services researcher with over 250 publications, and she's been continuously funded for over 25 years. She has received a number of distinguished awards and recently became editor of the journal Psychiatric Services. For those of you who don't know her, the kind of work that Lisa does really is focused on people with severe mental illness, and she's really focused on one of the prominent pieces of work that she's done has been on family psychoeducation, and she's also done a lot of work on co-occurring disorders, so co-occurring metabolic disorders or also co-occurring substance use. She's a real services researcher in improving the quality of care of those populations. And then, most notably right now, Lisa's the PI of one of the NIMH-funded RAISE study, which, for those of you who don't know it, that's a study focused on early onset psychosis, and she's heading the implementation and evaluation portion of that study. She similarly works on another study within New York State called On Track New York that, again, is aimed at people with early onset psychosis. On a personal note, I actually met Lisa when I was a public psychiatry fellow at Columbia. And that's at the time when I just started my career kind of looking at health systems and trying to figure out how to improve care on a systems level, medical care for people with severe mental illness. And what I noticed about Lisa was not only was she a brilliant scientist, but she's a true public psychiatrist, and just her heart is in improving care for people served within our public mental health care system. She's creative, pragmatic, and perseverant, and in my opinion is a true role model for all of us who are working in health services research. So thank you so much for being here.
Okay. Good morning, everybody. Really wonderful. Thank you so much for the introduction. I'm really happy to be here. I bit off quite a bit this morning with the talk, so I'm going to be moving, okay? It's one of those things where I'm a New Yorker, you know, so I talk fast. The title of my presentation, the reason for it will be obvious, but I do want to give credit to my mentor, Howard Goldman. When I was telling him about these ideas that I was struggling with, and I don't know if any of you guys know Howard. He was here many, many years ago, the former editor of Psych Services. He said, "Oh, it's Goldilocks and the Three Bears," so in some way the title is a little bit of a kind of a thank you to Howard. Okay, so my objectives are really to sort of to try to tackle this issue of the tension between evidence, which is kind of our science, and dissemination, which is our practice. And I'm going to use the schizophrenia port, the schizophrenia patient outcomes research team efforts, which I'll tell you about, to kind of tell the story. But my hope is that you see that this is not just a talk about schizophrenia, but it really is a talk about psychiatric and behavioral health practice, and in fact, general health practice as well. We'll see if I can pull it off. So the race is on, kind of mixing up all kinds of weird metaphors here, but you've got evidence, and what I mean by evidence is our work in which we figure out what works. And we think of that typically as efficacy and effectiveness types of studies, which require that we, assess fidelity. What is it that we're measuring? What are the active ingredients? What are the mediators and moderators? And what is the treatment for whom and for what outcome? And I think of those as sort of some of the key effectiveness questions. And then we have implementation, which implementation is essentially the notion of bringing evidence, at least as I thought of it before, bringing evidence-based practices to scale. And the activities involved in implementation are rather different. They're overlapping with those of sort of the development of evidence, but they're not the same. When we're talking about implementation, we're talking about getting stakeholder buy-in, we're talking about financing, we're talking about training, we're talking about integration with other services. It's a whole different set of challenges. And so sometimes in my early world, immediately post my training at Cornell, and then in my early work at Maryland, kind of the thing was implementation typically lags behind evidence. Okay? But there's also, I have discovered, and this is in some sense part of the whole point here, is that there are times when evidence lags behind implementation, and so that's kind of this notion of, well, what is just right? And so this is about the only real connection to the Three Little Bears. So for all you child people here, I'm not going to be like talking about sitting on chairs and stuff like that. It was just this notion of sort of the challenge of what is just right. So the port. And so this is going to be the activities that I kind of build my discussion around. And the port is really, it was kind of my psychiatric research, childhood, adolescence, and young adulthood. My very first job after my research fellowship, which I quit because I didn't like chopping off rats' heads, was with Tony Lehman and Neil Steinwachs. And Don Steinwachs was at Hopkins, and Tony was at Maryland. And together they got the first port funded from the Agency for Healthcare Policy and Research, which is now AHRQ. And this was at this time, which was in the late 80s, evidence-based practice did not roll off the tongue, okay? It was really sort of, it was a concept that I think people intellectually understood, but it didn't have a lot of, people didn't believe that there were evidence-based practices. And so there was a port that, the port series was designed to identify evidence-based practices and then implement them. And there was, the first port was on back pain. People, that port discovered that the treatment you got for back pain was not very much a function of the evidence, but was a function of where you lived. Okay, so this was very, very, almost a revolutionary idea that, if you happen to be in a community where the doctors did this kind of procedure, that's what you got. If you happen to live in the other community, maybe you'd get watchful waiting. And it really evidence didn't seem to have such an impact on what people got. So we got the first mental health port funded, which was the schizophrenia port, patient outcomes research team. And in fact, there were 3 efforts funded. And I'm going to walk you through a number of different interventions over these 3 ports. And so the first port, as I said, Tony Lehman was the PI. It was from 1990 to about 1996. And that produced, one of the products of that port was treatment recommendations. And again, this was before, the era of a million practice guidelines and the NICE guidelines and the this and the that. It was really it was novel at that time. And then there was a second port funded through a center grant that went to Don Steinwachs, and this was, the idea here was, did the treatment recommendations need to be updated, pending a review of the literature, and that produced the 2004 treatment recommendations. And then finally the last, and probably the most recent and probably the last port, because nobody wants to do it anymore, and the group of us that was there doing it at Maryland has kind of dispersed, and even the whole science of review has changed enough in the last decade that it almost seems like you'd have to think about it a different way. And maybe that's part of what I'm going to try to demonstrate to you. But at any rate, we did have a third port. This one went to a young faculty member, and we funded the effort through an R13, which is actually a grant to convene a meeting. So we had to be increasingly creative about how to fund these efforts, and that produced the 2010 treatment recommendations. So this is going to be the backbone of kind of my thinking with you about the tension between evidence and implementation. So this was the first paper from the very first port that we published, and in that particular project, we identified the recommendations, and then we were actually funded to do a study of the extent to which practice or individuals' care conformed to those recommendations, okay, which is probably half the papers I get now in psych services. So that's gone from being sort of a kind of a novel type of thing with almost like a cottage industry. And so here you see, this was just, I'm going to come back to this paper. This shows you the extent to which there was conformance around each of the different treatment recommendations that we offered in the first port. This is the second port, and again, just to give you the backbone, we were not funded in the second port to do a study of conformance to treatment, because that's actually a pretty expensive proposition, whether you're going to do it with primary data from patients or whether you're going to use claims. In this second port, we were able to just survey clinicians to ask them about the extent to which they thought it would be easy or not to implement the recommendations. And again, the point being that there's not this kind of straight line shot from the practice to implementation. And it sort of began this notion of, well, what really happens in that gap? And then finally, this was the last, the cover for the last set of recommendations that we published. Okay, so now we're going to jump into the first of 4 examples of recommendations or possible recommendations, and we're going to look at the tension, again, between evidence and implementation. So the first one we're going to look at is employment. Okay? So in '94, we had a treatment recommendation that was, again, based on a pretty strong set of RCTs, that persons with schizophrenia who have any of the following characteristics should be offered vocational services, and the person identifies competitive employment as a goal, has a prior history of competitive employment, blah, blah, blah. You'll note, for those of you who are interested in supported employment, that at this point, the recommendation actually did not focus exclusively on competitive employment. There was more of a inclusion of sheltered work and transitional work practices. And then you'll see that here, to what extent did individuals receive services that were conformant to this recommendation? And you'll see here, in our inpatient sample, about 30%, and outpatient sample, 22.5%. So again, we have this notion, which sort of was my, if anything was going to characterize my research, childhood and adolescence, it was this notion that implementation lags behind evidence. And that's what we had here. We had the evidence, and then we had implementation not really keeping a pace with evidence. And then in 2004, this recommendation continued, although here you see that there was much more of a focus on competitive employment and the evidence-based practice individual placement and support that was developed by Debbie Becker and Bob Drake at Dartmouth was sort of starting to amass its evidence base. And then finally, in 2010, we have very strong evidence for the impact of individual placement and support, which is a coordinated treatment model that it produces competitive employment. And you'll see articles in the American Journal of Psychiatry supporting this. So then the question becomes, again, what is this? 15 years later or 10 years later, is this practice any more penetrated into care? And what you see here, this is actually from a SAMHSA survey. It's kind of hard. Like, you'd think we would know, like, what happens out there, but it's actually hard to find out what happens out there, which gives some of us jobs, I guess. And of course, the other thing, just so you know, I mean, for me, since I've always had a psychiatric practice through all of this, when I say supported employment is not happening out there, like 1.9%, I'm not being critical. I mean, I know how hard it is to do this in systems of care where it's not paid for, et cetera, et cetera, et cetera. So, you know, I'm not here in any way, shape, or form to, in this case, to criticize the profession, although I do criticize the profession sometimes, but that's not my purpose here. So what you see here is, again, I think here's a fairly clear situation, or maybe it's not so clear, but maybe it is clear. Implementation lagging behind evidence in the case of supported employment. The research shows, it's really be something about this research. Okay, so but let's just think about this for a minute. Let's just think about why we have such a gap between implementation and evidence in supported employment interventions. And so there are many difficulties in implementing supported employment. You need to we have one funded approach, which tends to be the traditional VR approach, and then we want to substitute one for another. And one of the things you learn in work and implementation and even work in administration is that as hard as it is to start a program, it's even harder to stop a program. So because it means you've got a whole infrastructure and community that's used to doing X, and you want them to do Y. There are entrenched institutions, agencies, funding methods. In this case, traditional VR in many states, it's not in the mental health system, so it's really dealing with a whole other entity. Again, a substantial workforce shift. There's no training stream, and there still is actually no training stream. And then, the clinical belief that competitive employment is too stressful and will cause relapse, which is, in fact, not the case. In fact, if anything, it's the opposite. Okay, so then let's ask the question, is there a problem with the recommendation? So I'm going to put my clinician hat on. And, I think that we have to, this notion that everybody who wants employment wants competitive employment, and that there's one way to do it, I think feels very uncomfortable for many clinicians. Maybe there are some patients who like that supported workshop, and maybe they're not going to be competitively employed, but that's kind of what they want. And then, of course, whenever I review a paper, and I review papers not infrequently on this topic, and maybe I'm giving myself away, but they always start out with the large majority of people with severe mental illness want competitive employment, and I've never seen an adequate reference to that. So, but the point is that, I think this notion of, there are some reasons that we need to work on as to why this practice has had such limited penetration, but I would just say this is, in general, a fairly clear case of implementation lagging behind evidence, and I think some effort now to fix that problem. Okay, so now we're going to go from employment interventions to family interventions, all right? And so in 1994, when we did the first port, there was actually a pretty robust evidence base for family psychoeducation in the care of people diagnosed with schizophrenia, as Ira Glick knows, one of the early pioneers in this approach. And so our recommendation, which was an A-level recommendation, so that suggesting that very, very strong evidence with randomized controlled trials, multiple ones, patients who have ongoing contact with their families should be offered a family psychosocial intervention that spans 9 months and includes education, support, crisis intervention, and problem solving. Okay? And now let's look and see what was happening out there in practice. And you see there is very little family psychoeducation. And in fact, this is even an overestimate of what was happening out there, because these numbers don't represent an actual intervention. They just represent family contact, okay? So which is a far cry from the intervention, okay? Very, very strong recommendation, very strong evidence base, almost no implementation at that time. Okay. And we move forward with the 2004 recommendation, almost the same thing. And then, actually between the first and the second port, I'm a family member. I have a brother with schizophrenia, and I'm very, active in the family community. And I start to hear about something called family to family. People here heard of family to family? Okay, so many of you have. And we were hearing about it. Well, I maybe even got invited to go to a training. And I sort of said, well, what is this? And I learned that it is a structured 12-week program that is delivered by family members for family members. It's outside of the clinical treatment system. It was developed by an amazing woman whose name is Joyce Berland. She's a psychologist. She's also a family member. It uses it uses a trauma recovery and stress coping model to help families, and it has a very generic, broad-based curriculum. Whereas the family psychoeducation for schizophrenia is really more illness specific. This was kind of for pretty much all comers. The only admission requirement for family to family is that you're a family member. You can be a consumer. You can be, and again, it's not a treatment. It is an offering within the self-help community, essentially. And so Howard and I actually did a survey of mental health, state mental health program directors throughout the country in collaboration with NASHBIT, and we asked the question, very simple question, like, the higher up your respondent, the shorter the survey needs to be. So we had like 4 questions. And we asked them whether they sponsored or funded any family support programs in their state. And this is what we found. We found that by far the most supported intervention was, at the state level, was family to family, and only 7% of states, and we had a pretty good response rate, supported the evidence-based practice. And so here you start to see the opposite, right? Before we saw evidence in front of implementation, now we're starting to see implementation in front of evidence because there was not a single bit of data that this program worked, okay? No data. Yet it was all over the country. And I'm scratching my head because all I'm thinking about is, the gap between practice and implementation. And so then at that point, having sort of beginning to understand this, we got an R01 to study family to family, and we did that in Maryland in partnership with the University of Maryland and NAMI in the state of Maryland, and we did an RCT. And we found, in fact, that family to family was effective. Now, it wasn't effective for patient relapse. It's not a patient intervention. It's an intervention for families. And so we found that what it did was it improved families' functioning, it reduced distress, it improved knowledge, it improved a positive experience of caregiving. And what was really amazing about it, from my standpoint, was that the benefits didn't go away after the program ended. I mean, what psychosocial or psychopharmacologic intervention can boast that, right? That the benefits persisted for as long as we could measure it. And that sort of, so, am I doing a commercial for family to family now? I don't know. Oh, wait a minute. Am I not supposed to be doing commercials? Oh, wait, sorry. Okay. That was a weird political allusion. Anyway, what was I? Oh, yeah. So we found that it persisted, and I don't remember what I was going to say after that, but I got so carried away with my, and so Joyce, actually, when we were talking about doing this study together, Joyce said, this is not an intervention. I kept referring to it as an intervention, and she says, it's not an intervention, darling. That's what it's a movement. It's a way of living. It's consciousness. And I think she was right, actually, because people are sort of forever changed, by participating in this program. Okay. So we then incorporated the brief intervention into the next round of the port, since we were starting to amass some data that these interventions had some evidence, and that's what you see in 2010. But again, the SAMHSA study that was looking at, from patient standpoint, what they were getting, very little family psychoeducation, which kind of led to this kind of dichotomy. On the one hand, with the family-to-family piece, evidence was starting to catch up to implementation, and maybe it was just right, but with respect to clinical services, with respect to, interventions that could affect patients' symptoms and relapse, we were still in a very bad place in terms of evidence, continued evidence outstripping implementation. And in fact, you couldn't get a study funded in family psychoeducation at this point because we're like, what's the interesting question here? There's no question about the effectiveness of this program. So a number of us who are kind of in the family, there's millions of us who have family members in psychiatry and psychology, and we were saying, what is going on here? Why is this not working? Why, the VA had done I think, a very well-funded effort to disseminate family psychoed. New York State had done a very well-thought-out, well-funded effort to disseminate family psychoed, and none of them worked. You'd get a few programs that would do it, and then it would die. I used to give a talk, when evidence-based practices fail, what next? Because the practice itself is good. It just did not appear to be disseminatable. And so when my colleagues and kind of thinking about this, we said, well, we looked at the barriers, and we said in these implementation efforts, the financing barriers were addressed. The clinician barriers were addressed. Clinicians were trained. They knew how to do it. They were enthusiastic. But there was not a single paper that we could find that looked at the patient's perspective on family interventions. All right? And so we just sort of said, well, maybe we've left out something important here, which is an inclusion of consumer and family preference. And you have to understand that, my mother would say, well, I'm not going to go to that. Let's it's too far and it's too frequent, and I just really want to talk to the doctor anyway. Okay, so I was getting this in my ear, and my mother is unfortunately often right, or maybe that's fortunate, but anyway. So we created an intervention that we tested, and it's called Reorder. And that stands for Recovery-Oriented Decision-Making for Relative Support. And it's basically a shared decision-making approach it's engaging the consumer in a shared decision-making approach as to whether they want their families involved in their care. And it sort of was, the zeitgeist at the time that we were doing this was sort of starting to, person-centered, shared decision-making. This was all starting to kind of be in the water. And so, what we said was, well, we really need, what we said to ourselves was, if someone were to ask me, do you want your family involved in your mental health care? I would say, it depends, okay? I would say, I would want this one and not that one, and I would want, in some ways, to call the shots. And that seems like perfectly, reasonable. So we kind of built an intervention around that notion, which was, again, I don't have the time to go into the actual intervention. It's very simple. It's very, very simple. Who's in your family? What are your goals? How might your family help you achieve your goals or not? And then let's try to build on those ways that your family members, and we, of course, had a very broad conceptualization of family, can help you, and then we'll do the same thing with the family. And so we created a manual. We did pilot work. This was actually in the VA, and we hypothesized that this front door, this front end to the intervention would increase family participation in care and increase the use of family psychoeducation. And so we did an RCT in the VA, and what did we find? We found that not only was there a 5-fold increase of family participation in care, but actually also patients, there was reduced paranoia, and we had hoped that this kind of shared decision-making approach would be empowering and recovery focused, and we did find that. It's a very simple intervention. Anyone can do it who is reasonably clinically trained. And so, it just sort of brings then this question of, well, all right, what is just right, and what have we learned? Because right now we're sort of in this space where we're trying to figure out what next. But if we step back and sort of look at this whole story of the family intervention story, you know, I want to kind of reflect on the just right. So how do we do the math with two connected but distinct practices? And when I say do the math, I mean sort of where are we with the evidence implementation tension? What is the appropriate benchmark? And I think this is really important when preference matters, okay? When increasingly, you know, we're trying to understand, you know, what constitutes reasonable dissemination and implementation, what constitutes care quality, when an important part of that formula is going to be dependent on something that may be unknown. And which we have to connect. So these simple graphics of this many % of patients got this percentage of patients got that is really insufficient because it doesn't tell us an important part of the formula. And I actually think that's part of what the problem was with the old family psychoed data. And then, and I'm totally guilty of this as having been in the family psychoed industry, the danger of treating everything as a nail when you have an EVP hammer. So, okay, we want families to be involved, so family psychoed. Well, wait a minute. You know, that practice may only really be reasonable or appropriate for this subset. And sort of our failure in this situation is sort of what intervention, for whom, for what outcomes. You know, again, implementation failure assigned to dig deeper to understand the so-called barriers, which is kind of what we did as we tried to understand why we were not able to implement this intervention. You know, in spite of, like, we were all waving the evidence-based practices flag, you know. I mean, that was my, you know, I practically wore a T-shirt, you know, all the time that was evidence-based practices, here we come. But then it was like, whoa, you know, wait a minute, we have to really think about this. And then I think, and this is going to foreshadow what comes next, underlines need to have consumer stakeholder input at early stages in the research process. Okay. Employment, family, now we're going to go on to the third story, okay? And this is the longest story, so it's the story that I have to talk fastest. And so in the third port, there was a lot of pressure around certain interventions to sort of say they were evidence-based practices or to create a treatment recommendation, and we really, and this is where Tony Lehman was kind of amazing. Way back even in the SGA era, he refused. Anyway, we had fortitude that we weren't going to be forced or pressured into saying that something was an EVP when we didn't think it met the criteria. But what we did do in the third port, in the third round, was we identified interventions which we thought were close, but which did not meet the criteria. And so what you see here are treatments for which the evidence is insufficient to support a treatment recommendation, psychosocial treatments for recent onset schizophrenia, cognitive remediation, interventions to increase adherence, and peer support and peer delivered services. And sort of, well, I mean, I don't want to again go into all the details about what constituted evidence, but if we could not say what the intervention was, for whom, for what outcomes, we did not have a recommendation. And some of the problems, like with peer support, you'll see there was no one thing that was tested. We couldn't actually say, this is the intervention, okay? So that was, you know, very simply, you know, if you want to hold something in your head, if we couldn't answer those three questions, we didn't have an intervention listed as a treatment recommendation. So but we created these what we called summary statements that kind of summarize the literature as we saw it at that time. And here is the one on early onset schizophrenia. The field of research is witnessing substantial progress and maybe on the cusp of breakthrough approaches. Research has examined these different individual interventions, CBT, family, supported employment, as well as these packages. But we just didn't see any specific, consistently observed evidence-based practice that we could list. And so there are monotherapies and multimodal intervention packages. So that's where we're starting. This was 2010, okay? Then comes RAISE. And actually, RAISE was kind of sort of at the same time as this. But remember, we published in 2010, so we were doing the work, you know, way back in 2008 and 2009 when RAISE was just kind of being released. And this comes from the NIMH website. Actually, these are slides that Bob Heinzen gave to me, and Bob is the director of the dissemination implementation branch at NIMH. But I want you to see this. The Recovery After an Initial Schizophrenia Episode initiative, RAISE, seeks to fundamentally alter the trajectory and prognosis of schizophrenia through coordinated and aggressive treatment in the earliest stages of illness. This project was aiming high. Okay, they weren't trying to find a new medicine that might increase, reduce symptoms by, a statistically significant amount. It wasn't trying to just identify, how to improve CBT. They were aiming for the gold ring. They wanted to, it was a big risk, I think, in sort of going out and making this this aspiration or articulating this aspiration. And again, I actually think this was amazing that they did that. So a number of us, applied for the RFP, and again, I just want you to see something again that maybe now sounds familiar as we think about the evidence implementation gap. The RAISE statement of work, so these were contracts, to develop, refine, deploy, and test an early intervention model that is relevant to the U.S. mental health system, engage community treatment partners, not academic research clinics, as partners, and so it was going to be in the community, and incorporate features for rapid dissemination, adoption, and implementation in community clinics. And so this was all built into the two RAISE contracts. This is where it gets kind of fun. On my end, there were two RAISE studies, and John Kane led the arguably I call it the larger RAISE, or the RAISE superior, the more important RAISE study, as it turned out, which was a randomized trial, which I'll tell you about. And then we had Jeff Lieberman was initially the PI, and then when our study was changed from a randomized trial to essentially a demonstration with some other tasks that NIMH wanted to do, I became the PI, as the work was much more in my wheelhouse. It was much more on implementation. So in our RAISE study, which was again the smaller RAISE study, not the one you've probably all heard about, we just did an open trial, an open demonstration of an evidence-based, our read of what was the evidence-based components of an early psychosis treatment program, and we called that RAISE Connection. We did this in New York State and Maryland, and what did New York State learn from this RAISE Connection program? New York State learned that this was doable, that this was successful. It had great support in the community from clinicians and patients. Even though we didn't have a control group, we could compare our outcomes to others observed in global trials. And we also happened to have a commissioner, a mental health commissioner, and this is where, again, the story becomes more about, it gets more complicated in mental health services. Mike Hogan was a commissioner of mental health in New York State at that time. Mike is an amazing person. He's also a sibling. And he was, I don't know if people know, he just oversaw the President's New Freedom Commission on Mental Health, very influential guy. And he was like, he was pissed that our study was downgraded to a non-randomized trial. But he also said, I believe this. This works. I've seen the data nationally. I've seen this work. It makes sense. New York State is going to do this. Okay? New York State is going to be out ahead and implement first episode psychosis programs. And that was actually the time I moved up to New York. We created something called On Track New York, which is actually not a research project. It's a program in the state of New York. I don't have a lot of time to go into some of the nuances of the name and how we presented ourselves. But the point is, we were off to the races in New York. Okay. What I want you to remember is there was very little data. There was no recommendation yet, and the other RAISE study wasn't even close to publishing its results. So again, thinking about evidence implementation, that's what I want you to be thinking about. We were off, okay? And this is a slide that shows you the contacts between NIMH staff and the U.S. Congress during this time period. And why am I showing you this slide, you might ask? The reason I'm showing it to you is because it demonstrates something. Does everybody see? So there were a few contacts in 2009, 2010, 2011, and then suddenly things changed in 2012. And the last quarter of 2012 was Sandy Hook. All right? I was going to ask you, but to see who remembered that, but because I'm looking at the clock, I don't have time. So, but what happened is that there was an enormous mobilization, whether we like it or not, in mental health around this episode of violence. Okay, and then what happened? The Consolidated Appropriations Act of 2014 happened. Okay, and here you see, what is that act? That act is now, for those of us in the early psychosis world, referred to as the set-aside, the first set-aside. So what this act did was it increased the funding to states for early psychosis by 5%. So each state's block grant got 5%. And usually block grants, states can do anything they want. This was different. This was earmarked. It was new money earmarked for early psychosis. It wasn't a lot of money. It was only $25 million, but it was, it wasn't nothing, and it was a way to seed these programs, and for there to be a requirement that the programs were required to follow evidence-based principles. So again, do we even have evidence? Do we know what the evidence is? Not yet, really. And then a paper comes out from Vinod Trihari's group in Yale New Haven, the STEP program, which is an early psychosis program. And again, the only reason I'm showing this to you is because it's data. And this data showed that their early psychosis program was superior to usual care for hospitalizations and for vocational engagement. So we're now finally getting some data after the federal allocation. And in the meantime, New York is off to the races still. And then finally we get the results of John Kane's early treatment program study. I will tell you that the day that this came out, October 20th, it had been embargoed. 10 of us were down at a congressional briefing organized by advocates to advocate for more money for early psychosis services, okay, on the day that the evidence came out. And so what happened next, over some time, these programs have been expanding, and the fear was that this allocation would be a one-off, but it wasn't. In fact, the allocation was doubled and is in the 20th Century Cures Act. So the additional now $50 million is going to be continued to be delivered to states for early psychosis treatment. And so, this is kind of the slide of my group's activities as we've, you see this timeline, starting with Raise Connection, and it was right in here that we started to have evidence, okay? And this is, again, a set of slides from Bob Heinsohn at the NIMH. And remember what their goal was. Remember what their goal was, that they were very focused on this kind of changing care, changing the world of care for early psychosis. And you see here the cumulative number of states with early psychosis intervention plans, and you see this incredible increase, which you can be sure the NIMH people are showing, so, because and Insel in 2014 went on record as saying, RAISE is the most important NIMH activity in that year, and shows what you can do when research is sort of appropriately applied to dissemination. And so you see here, these evidence-based programs are now called coordinated specialty care. Coordinated specialty care programs in 2008, in 2014, in 2016, and expected in 2018. So again, what I want you to see is this really dramatic, a shift, which was kind of sought by the NIMH early in 2008, and this is New York State's. We're building our programs all over the state. But all right, so now let's get back to this question, though, of implementation and evidence, and I think this is a very complicated story, because I would put forward that at least in the early portion of this, what I think was the more important expansion of these services, implementation was clearly outstripped. It was ahead of evidence. But it was this kind of complicated interaction where it wasn't really far out ahead, but it was, I can tell you when John Kane's, when that study turned out to be positive, Bob Heinsohn was in church thanking God. I mean, because if that study had not turned out to be positive, and it was just maybe barely positive, you know, they had staked a lot, and so, you know, there was risk-taking here, okay? So I ask, you know, is implementation ahead of evidence for early psychosis? And I would say, for long-term benefit, absolutely. We have no data, I hate to say it, but we have absolutely no data that these programs actually change the course, the long-term course of schizophrenia. We have a lot of evidence at this point that it improves outcomes in the short run, but long-term, no, we do not have that. So for long-term benefit, yes. For sure, I would say implementation is not ahead of evidence for the short-term benefit. And then, you know, you start to think about it. But we may not be able to realize the long-term benefits without building on the short term, so that in some sense, you know, we can't do research on and establish long-term benefits in a 2-year or a 5-year period. It's just not possible. So you really have to start small. What are the risks of sort of this approach, of this kind of horse race between implementation and evidence? One is, and I think it's something that we have to think a lot about, is overpromising and getting it wrong. And, you know, our field is sort of littered, you know, with the garbage of our promises that, you know, we were not able to bring to fruition. And so we have to think very, very carefully about what we say and to whom. And then, of course, you know, my husband, who studies and works with people who have more chronic disorders, this is the opportunity cost. What else could you be supporting? If we're kind of investing in this, you know, we're not necessarily investing in others, although, you know, this was new money. But then what are the risks of waiting for evidence, okay? This was the time. I mean, I would argue that it was sort of like the stars were aligned. To some extent intentionally, on the part of NIMH, they went at this, and I know Bob Heinsohn well enough to know that he was, you know, when Sandy Hook happened, you know, in some ways he was prepared for it. And they had to think about this strategy, and actually the advocates too. So there's this loss of opportunity never getting there, and also, I would argue, the loss of the short-term benefits, because even if we don't know that the long-term, you know, we had some evidence that there were short-term benefits. So, you know, reflections on this, again, the intentional focus of NIMH, of beginning with the end in mind, taking advantage of creating opportunities at the policy and human level, and then this notion of the need for sightlines, and I guess I've already alluded to this, which is, you know, how, you know, Bob was willing to sort of be enthusiastic about coordinated specialty care before he had the evidence from John Kane's study. But it wasn't that there was no evidence. There just wasn't a lot of evidence and consistent evidence. But there was some evidence. There was evidence from international studies, these monotherapy studies, and some of these team-based studies. So it was like he wasn't getting out too much in front of the evidence with the implementation. And then, you know, I know that Pat McGorry was here, I guess. You know, Pat might say or make the point that we have to differentiate evidence needed to drive health system reform from evidence needed to establish the effectiveness of a specific intervention. And you know, honestly, like, that's getting into like a head that I'm still, you know, it's hard for me to sort out. But this intervention is as much about the care delivery system as it is about a treatment, right? So the last and shortest example I'm going to talk about are peer support and peer interventions. Okay, so we did not in the first 2 ports we didn't mention peer support and peer interventions. In the third port, we mentioned it only to say that we didn't have sufficient evidence to make a recommendation. So what we wrote, studies suggest that when trained consumers deliver traditional clinical services, outcomes are not dissimilar to when such services are delivered by mental health professionals, but the literature is small, there are weak experimental designs, and there were so many peer-delivered services, and you know, that we couldn't really make heads or tails of it. But at the same time, okay, that as we're writing, you know, our holier-than-thou analysis of the scientific literature, this is from Larry Davidson, who's been a real advocate in the peer world. Over the last 20 years, the practice of peer support has virtually exploded around the globe. with many more recovering persons being hired to provide peer support than ever before. Estimates place the number of peer support staff currently to be over 10,000 in the U.S., et cetera, et cetera. So, is this then a case where, again, implementation is ahead of the evidence? There's an emerging evidence base on this, and I recommend for those of you who are interested, Larry's paper in World Psychiatry is really an excellent summary. He kind of outlines 3 types of research. The first and the earliest body of research is where peer staff could serve in ancillary roles, and in those, outcomes, again, were at least as good. Peer staff could then serve in clinical roles, so becoming little, like clinician actors. And I'm saying it this way because I work with a lot of people who are leaders in the peer movement, and they really, that's like not what they want to be happening. That where they are now is this notion of peer staff assuming unique roles that only peers can fill, that are not clinical roles but are really more built on relational issues and relational, on relationships. And here, again, I think, I would still put forward that, the literature is emerging, but it almost doesn't matter, right? At least in much of the sphere of planning mental health care services today. And so here we are with this notion of, what is the right balance? And I think it raises, all of these stories, the story of employment, the story of family, the story of early intervention, and the story of peer support, and in particular, I think peer is, so this is questions about the nature of knowledge and evidence. And, when you really get into the peer support and discussing with not just consumer peers, but family peers, as I kind of discussed with my discussion with Joyce Berland, is that, we don't all agree on what is important knowledge or how to measure it. The notion of the PhD-E, the PhD in experience, which a lot of NAMI members talk about. The other considerations regarding sort of just right are the development of typology of programming. Again, that it's not just the intervention, but it's how the intervention is embedded in it's not even necessarily in a clinic, because some of these programs are not part of a clinic. They're part of the digital era, or they're part of a community agency. And then, again, and I think the peer leaders would say around peer support that this is not about peer interventions. This is about justice. This is about nothing about me without me. This is about system reform. At the same time, and I'm the researcher saying, but no, it's actually about an intervention. Like we actually, so there's this, I think both perspectives have merit. And so, all right, so then I'm going to just conclude by trying to pull this together. And there have been, a number of efforts to do that. This is the front page of a report from the Institute of Medicine, psychosocial interventions for mental and substance use disorders. I would suggest that this isn't just an issue for psychosocial interventions, but this group, this Committee on Developing Evidence-Based Standards for Psychosocial Intervention for Mental Disorders, kind of put out this diagram, which I think is useful in that it puts at the center of the wheel, if you will, engaging consumers, which I think is this kind of theme of all of the, or at least the family intervention and the peer intervention stories, and this notion of strengthen the evidence base, identify elements of the interventions, conduct independent systematic reviews to inform clinical guidelines, develop quality measures, implement interventions, and improve outcomes, and so forth, with consumers having input at every step along the way. But personally, I don't think this goes far enough. And it wasn't, I think it's a little bit more of the same. So I'm going to, this is actually a challenge that I'm, kind of thinking about in an ongoing way. And when I read this particular paper, I said, aha, I think this is satisfying. This helps me to kind of navigate this tension. And so this is the name of the paper is the adaptome. So now I'm always talking about the adaptome. Have any of you guys read this or seen this? No? Yes, a few of you. Okay. So David Chambers, who used to be at the NIMH Health Services Division, is now working at NCI, I think. They put forward this notion that we really need to challenge our assumptions, that we have thought, and I have thought for most of my career, program drift is bad. Okay, we have an evidence-based practice. Program drift is bad. We need to have fidelity. We need to measure fidelity, and we need to know what we're testing. That in some sense there's this kind of permanence of the evidence base, that we have IPS as this evidence-based practice for employment, and now we have it, and now we are going to implement it. And so this notion that dissemination and implementation comes after everything else. And this notion of the adaptome really says that's wrong. That's wrong. That is getting us stuck. And what he is basically saying, and what they are saying is, and this is, sort of in the history of science, usually a lot of people have the same idea at the same time, but they're just expressing it slightly differently. So there are other people who are also writing about this. Okay, yeah, I'm almost done. And so we talk about this notion of the adaptome, which sort of starts from this assumption that any implementation effort or any treatment develop effort has to kind of be built around adaptation. But it's not just kind of random. We're not just going to, let's do what we want to do and see how it goes. It's systematic and organized and empirical, right? So it's not just adaptation, random adaptation, which we're not tracking, but it's organized adaptation. So they talk about 5 types of adaptation: by whom, what is modified, at what level of delivery, what are the context modifications, and what is the nature of the content. And then Greg Ahrens also put forward this notion of a dynamic adaptation process model, which identifies core components and adaptable components, and then identifies 5 stimuli for adaptation: client emergent, provider knowledge, provider skill and abilities, available resources, and organizational adaptation. So what is embedded in this and what is implicit in this is that every effort to implement a program, whether it's an established evidence-based program like we saw in the port, or even something that's evolving, when you implement it here at UCSF, in your program, in your clinic, or in Topeka, Kansas, or in Brooklyn, New York, there will be this automatic adaptation process. We want that to happen, but we need to do it in a way that is scientific, if you will. And so this is this visual representation of the adaptome that Chambers and Norton kind of put forward. And I don't have to read it, but again, I think you can see that what it's trying to do is sort of cover the various inputs into the delivery of a program. So I'm just going to conclude by sort of talking about, when I think it raises the question of, all right, when is an intervention ready for adaptation, right? Because it's not like, I'm going to go home and make up, some kind of program myself and then say, okay, everybody, let's start adapting it. No, that's not really appropriate. There needs to be, so if we're going to put forward the idea that an intervention can be, that it's actually healthy for an intervention to begin an implementation or dissemination process before it is fully formed, right? But how formed does it have to be? in order, for it to be reasonable to begin this process of implementation and dissemination. So, go back to that list, the third port of interventions that have some evidence but aren't ready for a full treatment recommendation. And I don't, this is where I don't know the answer to this, but, I would put forward that, there needs to be some scientific evidence, rigorous scientific evidence, and probably at least one RCT, if not more. But perhaps not meeting, the full standards of the port criteria, which was, what, for whom, for what outcomes, and multiple RCTs. There needs to be, importantly, also, I think, stakeholder support and buy-in. There is no point in moving it forward if there is not sort of some engagement with end users and policymakers and finance people. And there needs to be, and this is where I think, we have to be very disciplined, structure and process to support the study of adaptation. That if we just do this without that kind of systematic backbone, we're not going to learn. We're not going to learn. And sort of this, I'm not abandoning, my support for EVPs for something that isn't going to teach us something, right? So in summary, so in the world of science and practice, evidence can lag behind implementation, and implementation can lag behind evidence, but need to mind the gap. That's kind of, minding the gap is kind of my version of not being, too big a gap either way is likely problematic. I think the newly developed notion of adaptation within implementation science may begin to pull this together. And honestly, I was not a big fan of implementation science. In fact, I just found it so boring. But actually, to me, this is really interesting. It sort of created an engine. Favoring and structuring an ongoing measurement-guided approach to understand the interaction between implementation and evidence. Factors influencing which way it will go, and I mean in terms of what's actually going to end up being the delivered evidence-based approaches, but the extent to which I think scientists join with a range of stakeholders and vice versa is critical. And then I would just, ask that we still need to kind of think through this line between a health system reform and what is right, what is a principle, and kind of what is more of an intervention within a fair and just healthcare delivery system. And then finally, just as Baby Bear goes, just right is not static, and requires attention and ongoing monitoring. So thank you.
Yeah, I just have one question.
Sure.
Rests on consumer engagement. And I'm wondering if there's a developing science around consumer engagement for projects like this.
Yeah.
And if there is, what's the state of it?
Yeah. Well, I think that there is a science around engagement. What the things that we have to do or the things that are reasonable. I'm trying to sort of understand completely your question. There's, yeah.
About what works in engagement.
Yeah.
So
okay.
We sort of talk about it, but that's kind of the elephant.
Okay. Well, yeah. I think that if you have an idea, okay, for an intervention or an approach or whatever, I've been mostly in the psychosocial world, but you talk to 10 different or 20 different or some reasonable number of people who would be our end users, and I include clinicians and consumers, because we're not going to get practices out there for the most part if our clinicians don't want to do them either. So and you're not getting any hook. You're just it's like you're just dead in the water there. Then I think you have to find out why and maybe look at what you're offering. I think what mostly happens, at least in my experience, is that you get it a little bit right, but you need the participation of stakeholders to get it more fully right, or at least right enough to move to the next step. I think there's a difference between engaging consumers, like a lot of what we talk about, and I have to give a talk to OMH in New York, in a few weeks on, engaging consumers in ACT teams and engaging consumers in this treatment or in that treatment. That's a slightly different question, I think, or challenge than engaging stakeholders in the science of intervention, development, and testing.
Right, that's the question I'm asking.
Right.
We can create structures to make it easier for, clinicians to do certain
Mm-hmm.
And I don't know that we've looked very carefully at what we need to do to adapt things to consumers.
Yeah.
And that's what I was asking, if you're aware of any science.
Well, I mean, community-based participatory research would be sort of the science, that one area that sort of lays out methods. But, I mean, it can be anything from, honestly, like I usually think about it being really simple, just even a survey or you're trying to get input, and you're trying to, and then you want to hire people who represent to some extent these groups on your teams. So, okay, yeah.
The interventions that you mentioned that were low cost and widely distributed were family to family, peer to peer.
Mm-hmm.
Maybe not interventions, but movements.
Right.
And we're like communities. So it's like it takes a village to make something like this happen.
Mm-hmm.
So what's being done to look at creating communities, and specifically I'm wondering, is there any talk about looking at evidence of old models like asylums, like having people live together, work together, spend time together, because that was something that was implemented before there was evidence.
Yeah.
That we should get rid of this.
Yeah.
Is there any, there was the JAMA editorial a couple of years ago, Bring Back the Asylum.
Right.
That's being actually discussed.
Well, it's sort of, the irony of all of this is that, in some sense it's back to the future with the idea that, it was only with sort of the evidence-based practice movement that the identification of evidence-based practices that even allowed us to say that evidence was lagging behind implementation, because before we had evidence, we just did stuff, and some of it worked and some of it didn't. But, this is where it gets complicated, because it gets to where values and principles, I think, are play a very big role. And so if you talk about the notion of asylum, it sort of clashes with another, I think, really prominent principle now, which is that of inclusion, community. And I think that from a practical standpoint, it would be very, very difficult in these days to do a study of asylum, because, it would sort of run counter, I think, to some of the current zeitgeist. I mean, look, I have a brother. My brother is a 60-year-old man. He's in state hospital now. Okay? He's been in the hospital for most of his life. And I thank God in New York State that, he's got that. I mean, he's probably got dementia now. I mean, it doesn't look like he's got schizophrenia anymore. But, New York State is like a freak of nature in terms of, like, the state hospital beds and all of that. So, I mean, I guess, let me see if I can answer your question more directly. I think that creative people, may find ways to revisit some of those questions that I mean, in some ways, there was either premature closure about them for sociological or political reasons, but I don't see how, like, that particular question is going to, I mean, maybe the way to answer it would be to sort of think about how it may have been adapted and is now being supported in communities where people are actually helping each other and living together, but we can't, it wouldn't be called asylum, you know what I'm saying? because, the language is such that it would be difficult.
But just real quick,
Yeah.
you said there's asylum versus community. This is San Francisco where we had one of the nation's last almshouses at Laguna Honda, and they had community. That's what some of the providers there thought they were providing
Yeah,
for the
yeah.
patients, and the patients lost. So it's a different definition.
Yeah. No, I completely understand. I think what's inclusion is sort of it's not so much community as it is inclusion. But, I see what I think, honestly, I'm repeating myself, so can I just go ahead? Yeah.
So, you alluded to this in various points in the talk, but it's something that keeps me up at night sometimes or not frequently, which is, basically the issue of going from evidence-based practices to implementation, and in a way that has fidelity that we can trust. And it seems to me that one of the limitations that we face as a field in connection with our non-pharmacological interventions is that we don't have a systematized way outside of the academic research programs and maybe some other limited programs through counties of ensuring that clinicians and clinical settings that purport to provide evidence-based practices are actually providing those practices. And what's more is that I haven't heard a lot in your presentation about the kind of infrastructure and resources that would be needed to support that kind of monitoring or quality assurance on an ongoing basis. Because if you think about it, the drugs, the chemicals in the drug, they don't change over time, and 10 years from now, clozapine is clozapine, but now you've got a new crew of clinicians, and because you were doing evidence-based practice 10 years ago, doesn't mean that the next generation of clinicians you hired are doing that. And it just seems to me that it's a bit of a wild, wild west where people can advertise that they're doing evidence. They can say, as people do, we do CBT, but you start to scratch the surface a little bit, and it's not really CBT at all. So how do we
No, it's a great question. So let me a couple of thoughts about it. First, I think the NIMH is actually quite aware of this problem, and essentially it's the field having tools. So I don't know if any of you guys went in on this, but there was a recent RFP to create scalable fidelity tools. Because the problem with most of the fidelity tools that we have is that they're so labor intensive, they're just not affordable. And so this particular request for proposals was focusing on how to develop some scientifically validated strategies to measure fidelity for particular practices like CBT or IPT. I was a part of a proposal that we didn't get funded, but that's what we were after. And what we were using was we were using like a digital strategy with patients giving feedback right after, and so it wouldn't take a lot of labor. But I think you're absolutely right. It is a problem. I think a second way of thinking about this, or a way of addressing this, is this whole issue of measurement-based care. And I see that as making some inroads. In larger systems, maybe not here, but it is. I know in New York State in 5 years, because the Medicaid system is going to be built around value-based payments, and so there's going to have to be a shift in how the community mental health centers that I interact with do business, and they know that. What we are very limited by, particularly in the SMI world, not so much in the integrated care world with more common disorders, but we don't have a PHQ-9. We don't have the measures yet. There's a real problem with measures, and I know that's also being worked on. So you're absolutely right, and I think again, if I see what's happening nationally is there's starting to be these consolidated practices and organizations which are imposing some order on this. Now, I'm going to answer this as if I'm Vinod Trihari. So Vinod, I don't know if any of you guys know Vinod. He's at Yale. He runs the early psychosis program. And he would say, I don't care about fidelity. I only care about outcomes. Okay? And all this stuff on fidelity is a waste of time. I want to give you, if you're getting the outcomes, I don't care what you do. All right? And so we have this, and Vinod does early psychosis research, and I think there's a happy medium. And then you also have methodologic problems in terms of risk adjustment and stuff like that, because an outcome in this place isn't the same as an outcome because you've got different populations, so you have to be able to do that. But I think it's not an illegitimate point. And so we don't, as in the psychosocial world, we don't want to get trapped in the concrete boots of fidelity, honestly.
If I could just quick follow up. Thinking about the rollout of measurement-based outcomes in our practice, one of the things that I'm troubled by is that the scales are now showing up in our electronic records to be completed, but certainly when we do these kinds of scales in research, particularly those that are not just self-reported from patients, we have to attend a lot to the training that's involved in doing those measurements. And sometimes I think that just by putting the scales in place that we're fooling ourselves that we're now doing objectively measured outcomes without attending to the difficulties or challenges of doing good measurement.
I couldn't agree with you more. And, just putting a measure in place is not doing measurement-based care. It's really, like, we're struggling. So in our On Track New York, we have 21 sites. We collect a lot of data, and the state helps us support data. And we provide data back to our teams. We give them how they relate to the larger group and their own data. But you know what? We actually are just putting in a grant, because I don't think we know how to do this. Even from as simple as how do you visually represent data so clinicians who aren't really trained can understand it. And I was like, my team was telling me, Lisa, we're giving them these data, but it's not useful to them. And I'm like, oh, because they don't know how to read graphs. I was being really and I was like, oh, I realize now 6 months later that I get why they're not getting it, because we didn't really do a good enough job in figuring out what they need and how they need to see it. So, every solution begets 15 other problems that we have to solve. But everything you're saying is right, and I guess it's the chase, So, yes.
I just wanted to riff off Dan's concerns with the other side of the coin. So Dan's concern is around fidelity for us as clinicians actually implementing these evidence-based practices if we're even aware of them.
Yeah.
My question comes from the patient side, and I like the idea of engaging stakeholders from the start. But I'm thinking about outside of psychiatry, the early era of the AIDS crisis and the push for use of antiretrovirals before the evidence base was solidified for a very good reason. And, consumers, if you want to use that term, pushed for the use of antiretrovirals and went to other countries to secure them. And I'm thinking about that in terms of early psychosis. In our early psychosis clinic, too, a lot of our patients and families are very eager to implement whatever they Google or heard from other folks about what they want, and we want to be able to provide for them the best resources. So I'm all for stakeholder engagement, but I'm wondering if is there concern around too much? It's not too much stakeholder involvement, but is the driver's seat placed too much in the consumer side? Where's the
right. Well, and that's also a really great question, and I would separate out the decisions that we're making around treatment development and research and investments in implementation at a programmatic level. So for example, in our early psychosis program, we don't have a cognitive health piece. Okay, we don't have CogREM. We don't have any of it for a whole bunch of reasons. But I think it's time for us to think about cognition. Because I think, how can you work with people with schizophrenia and not pay attention to cognition, right? But we're doing this in a systematic way, with science, with my training team, with consumers. In other words, we're sort of and looking at, well, how do we read the evidence? What do we think would work? What's not going to have people sitting in the clinic all day when actually we really want them in school all day, or we want them at work? We don't want them sitting doing CogREM, 8 hours a day. So that's one level, and this is where, again, and so the part of this is that you have these different voices, kind of talking together. And, if the problem is that there's too much risk associated, we don't know if this works, and yeah, that's great if you want it, but the fact is that it's ethically, it's not. We run afoul of our ethical obligations if we prescribe something that actually could kill you and may have very little potential to help you. But at the level there's then the level of the patient and the provider, and that's where I think shared decision making is a very nice model, because what does shared decision making do? It connects the knowledge and the scientific knowledge and the medical knowledge that presumably the practitioner has to the values and the preferences of the patient. And so that is, and it's very well articulated. When there's reasonable evidence. When there's not evidence, it's a little bit challenging. But and then you just say we don't know. Then you just articulate the limits of the evidence. So, but that's, I think that's, and then maybe if we think about the adaptome being the model for the programmatic, and then the shared decision making being the model at the patient level. So.
Yeah, I like how the talk kind of was speaking, or at least how I heard it, from the iterative part of it, and adaptation. I guess I want to drill down into kind of the provider level, because I know from our primary care colleagues with kind of guideline overload.
Yeah.
And getting a lot of these evidence, listed in and kind of thinking on that level. And as you're kind of going through the Center for Practice Innovation in New York and trying to roll out different evidence-based interventions, how are you navigating, or how do you think about that?
Yeah.
And here's a new, what we think seems pretty good, large body of research.
Right.
How do you help the systems deal with that?
That was actually a challenge faced by the Robert Wood Johnson project that Bob Drake, and there was a whole bunch of Kim Muser. They had 6 EVPs, and you couldn't. What they learned was, and they did rolled out these EVPs in different agencies, and they learned that you can't, one agency can't do every single one. But we're at least in the Center for Practice Innovations. There's not a lot of. It's pretty straightforward. We have assertive community treatment. We have individual placement and support. They're co-occurring disorders treatment. So they're very robust. They're reinforcing, and they're not competitive. But then there are a lot of things that we don't choose to do because they're too complicated for us, and it would require priority setting that we're not in a position to do. Well, anyway, so that's. It's interesting, but what your question raises another issue, which is, again, happening in the early psychosis world. So let's just say you have 5 different interventions that should be a part of an early psychosis program. There's some independent evidence for CogREM. There's some independent evidence for CBT. There's some independent evidence for substance abuse treatment. There's independent evidence for suicide prevention. There's independent evidence for family psychoed. Does that mean you have to do all of them? To be an evidence-based approach? I would put forward not only would I say no, I would say there's no evidence for the fact that the combination of all those pieces is the evidence-based approach, because then again they may be competing with each other. They haven't been tested together. So, how then do you, well, anyway. Okay. Okay.